Hi, everyone. Good afternoon. How are you? Good. Well, my name is Eric Stoken. I'm the director of the Center for Social Science Scholarship, and I'm thrilled to be here today. This is certainly one of the exciting programs that we get to co-host with departments, and we are absolutely thrilled to have Dr. Gordon Hall here today. The Social Science Forum has actually existed for more than 25 years now and has included a large range of just phenomenal speakers, and we're thrilled to have Dr. Gordon Hall in this lineup. I did want to note that our next Social Science Forum will be held here on April 16th at 4 p.m. in the Library Gallery. The History Department will host its annual Low Lecture. Amber Mitchell, curator of Black History at the Henry Ford Museum of American Innovation, will present For Generations Yet Unborn, Observations and Challenges in Black Public History. So it should be a wonderful talk. You can find details on this event and much more at socialscience.umbc.edu. CS3, or the Center for Social Science Scholarship, is also on LinkedIn, Blue Sky, and all the other social media platforms. You can also find us on the MyUMBC Event Center, and we host Retrieving the Social Sciences. This is a podcast aimed at elevating the social sciences, hosted by Dr. Ian Anson in our Department of Political Science. Thank you again for being here today. I will now turn things over to Dr. Laura Rose, Associate Professor and Associate Chair in the Department of Psychology, to introduce our guest.
All right. Good afternoon, everyone, and welcome. It's a privilege to introduce Dr. Gordon Nagayama Hall, a distinguished scholar whose work has advanced the field of psychology in many meaningful ways. Dr. Hall earned his PhD in clinical psychology from Fuller Theology Seminary. He's held academic appointments at institutions throughout the country, including Kent State University, Penn State University, and for 19 years at the University of Oregon, where he's currently an emeritus professor. Dr. Hall has also held various leadership positions. He has served as Director of Clinical Training for the University of Oregon Psychology Department, Associate Director and Interim Director of the Research for Center on Diversity and Community at the University of Oregon, and has been President of both the Asian American Psychological Association and the APA Society for the Psychological Study of Ethnic Minority Issues. Dr. Hall's other outstanding service to psychology includes serving as editor-in-chief of the Journal of Psychological Study of Culture, Race, and Ethnicity, a consulting editor of the American Psychologist, and as a member of the APA Council of Representatives. Dr. Hall's research focuses on culture and mental health, health disparities, cultural adaptations of psychotherapy, and Asian American psychology. And his work has been funded by the National Institute of Mental Health and the National Institutes of Health. Dr. Hall has authored more than 100 peer-reviewed articles, edited books, chapters, textbooks, and more, and his work has been published in a variety of outlets, including the American Psychologist, the Journal of Cross-Cultural Psychology, Psychology, Health, and Medicine, the Asian American Journal of Psychology, among others. His scholarly impact is reflected in an H index of 54 and an I-10 index of 93, metrics that underscore the broad reach of his research. Given his outstanding contributions, Dr. Hall has received numerous honors, including 2 Lifetime Achievement Awards, one from the Asian American Psychological Association and another from the American Psychological Association Society for the Psychological Study of Culture, Ethnicity, and Race. Additionally, he has been honored with 2 APA presidential citations, one for his contributions to the task force on strategies to eradicate racism, discrimination, and hate, and another for extraordinary leadership in advancing multicultural psychology. Today, we have the privilege of hearing Dr. Hall as he shares his research in a talk titled Making the Invisible Visible, Reducing Disparities via Personally Relevant Interventions. Please join me in welcoming Dr. Gordon Nagayama Hall.
Thank you, Dr. Rose. It's an honor to be here, and I want to introduce my daughter, Coco Hall, who's a master's student at Johns Hopkins University in Public Health, and she'll be finishing next month, so our family will be back to see her graduate, and her partner, Cray Bryan, who's a senior data analyst, so they're joining us today, and I'll be spending some time with them this weekend, so I'm happy to be here for that reason as well. As you know, Cory Booker spoke on the Senate floor for over 25 hours, and I'm not going to speak that long because I'm not as smart or have the physical stamina of Cory Booker, but I will say that a few years ago I had a undergraduate student who came to my office hours and said, if I had an hour to live my life, I only had an hour to live, I'd come to your class. I said, oh, that was very touching. I said, why is that? And she said, because your lectures last in eternity. So I promise not to last in eternity, and I'll try to get us out of here so you can go have dinner. Okay, so this is an outline of what I want to cover. I'm going to discuss what Asian American mental health disparities are, discuss efforts on cultural adaptations of psychotherapy, also discuss our work on the personal relevance of psychotherapy, and then addressing these disparities with the personal relevance approach, and then trying to extend the reach of these interventions with a new app that my colleagues and I have developed. So Asian American health disparities, what are they? Well, first of all, who are Asian Americans? There are 22 million people with roots in more than 20 countries. 60% are born in Asia, and it is the fastest growing ethnic group in the United States, comprising 7% of the U.S. population. Disparities involve differences between groups, or one group's at a disadvantage. And if you look at this chart, you can see that Asian Americans are the least likely group to use mental health services during their lifetime. So about 1 in 4 whites uses mental health services during their lifetime. And it's about 13% of Asian Americans during their lifetime uses any form of mental health service. So there's this disparity. And the question might be, well, maybe Asian Americans don't experience stress or problems that would require them to use mental health services. But this is a recent study on 20,000 high school students conducted by CDC. And Asian Americans in this study were the most likely group to experience racism. Almost 60% had experienced racism, and racism increased mental health problems, depression, anxiety, substance abuse, suicide. And the mental health of Asian Americans was affected by xenophobic political language and high-profile attacks on Asians. This study is a few years old, but unfortunately we're moving into a period where these types of anti-Asian incidents are again on the rise. So one could say, well, still, maybe Asian Americans don't use mental health services because they don't need them. And in a study by Wayne Meyer and Nolan Zane and their colleagues, they examined the rates of mental health use of people in the community who are likely to need mental health services. So these are community surveys of symptoms that people are experiencing, and these surveys identify people who are likely to have a mental disorder based on anxiety, depression symptoms, substance use, psychosis symptoms. And of those who are likely to have a mental disorder, this is lifetime use of mental health services. Over half of European Americans use mental health services. So for European Americans, using mental health services is common, and the majority of European Americans, if they have a mental disorder, will seek and use mental health services. On the other hand, less than 30% of Asian Americans likely to have a mental disorder, so those needing help, did not seek help. So the minority of Asian Americans seeks mental health services. So the question is why this disparity might exist. Part of the reason for this disparity is the lack of funding of research on Asian Americans. So from 1992 to 2014, only 0.17%. So you see that small slice of the pie. That was a percentage of NIH clinical research projects focused on Asian American, Native Hawaiian, Pacific Islanders. So you might think, well, Asian Americans are a small group anyway, but Asian Americans, I mentioned, comprise about 7% of the U.S. population. So you'd expect quite a bit more research focused on Asian American health if, in fact, this research was reflective of the community. And this is all clinical research, not just mental health research, but this has to do with cancer or cardiovascular disease, aging. All research in NIH focused on Asian Americans only 0.17% of the time. And Carissa Chia, one of your faculty members here, and I and other colleagues have been involved in advocacy with NIH on this issue, such that we met with former NIH Director Francis Collins and discussed these disparities and these issues with him. This is a reciprocal process. So Asian Americans are invisible because they don't use clinical services, and because they don't use clinical services, there's not funding for this kind of research. There's not an awareness of Asian Americans. So there's this cycle of invisibility that's prompted by the underutilization of services. Mental health disparities are caused by face concerns among Asian Americans, and this is some work by Nolan Zane. So face is one's social reputation based on traits, attitudes, and values one presents to others. So that's one's social face or one's reputation in public or in a community. And face is saved by fulfilling roles as a member of a group, as a family member, as a person at school or a worker. So if you're a good family member, if you're a good parent, if you're a good teacher, good student, if you're a good worker, good supervisor, you save face by fulfilling those roles. On the other hand, loss of face can happen because of mental illness. So mental illness prevents a person from fulfilling their roles. So if you're not a good family member, if you're not a good worker, and you're not a good student or faculty member because of mental illness, you're going to lose face. And face concerns, as you might guess, prevent disclosure of symptoms and prevent help seeking. So much of this disparity of Asian Americans not using mental health services could be out of a fear of seeking services because of the shame involved in face loss when one has to admit that they have a problem. And not only admitting that you have a problem, but when you have a problem, it implicates your family and your support system. So there's a huge pressure not to disclose symptoms or seek help. One response to this disparity has been cultural adaptations of psychotherapy. And much of this work my colleagues and I have just described in an American Psychologist article a few years ago, and we discussed the universal level, which involves principles that apply to everyone. Most interventions that we have, most psychological interventions are assumed to apply to everyone. These are interventions such as cognitive behavior therapy that are assumed to implement universal principles of healing. Another level is a group level that considers cultural context, and this is where culturally adapted treatments come in, and this is concerned about the external validity of treatments. How does this particular treatment work in this particular cultural community. Finally, the individual level involves the individual situated in these group and universal contexts. How does this individual, with their cultural background, how do they respond to these interventions that are evidence-based? Fred Leong, my colleague, back in 1996, discussed an integrative model of cross-cultural counseling and psychotherapy, and he argued that any of these dimensions, universal, group, or individual, used in isolation has limited validity and utility in psychotherapy, but that has been the tendency. The universalists tend to believe that their interventions apply to everyone. The culturally adapted folks focus on culture and sometimes broadly apply their interventions to a whole cultural group, such as Chinese Americans, among whom there's much variability. And then others who focus on the individual sometimes fail to look at the context that the individual exists in. Evidence-based treatments are an example of this universal level of intervention, and evidence-based treatments are the integration of best research evidence with clinical expertise and patient values. And that, that's very laudable, and it sounds like it's a good thing for everyone. And indeed, EBTs are assumed to be universally applicable, but the evidence base for EBTs is primarily for one group, whites. So these evidence-based treatments were developed in labs and in clinical research settings, but the participants in these studies in the 1990s rarely included someone who was not white. The inattention to culture in evidence-based treatments is based on a default argument that, well, there's not evidence that non-adapted interventions are ineffective with diverse groups. So if these interventions work with different groups, well, that's enough. Why do we have to pay attention to every single group? Do we have to develop a different therapy for each different group? So it's a lowest common denominator argument that this group works pretty well for everybody, but this is not the highest standard of care for each group. It's a lowest common denominator. And evidence-based therapies have not reduced mental health disparities. So despite the good research evidence for these approaches, there still is this persisting phenomenon of Asian Americans not using mental health services, even when evidence-based treatments are available. In the 1990s to 2000s, culturally adapted treatments began to be developed, and there's two major types of adaptations. One is therapist adaptations. An example of this is therapist-client ethnic matching. So you train therapists from different cultural backgrounds to have similar backgrounds to the clients they serve. Another approach is therapist cultural competence. This is an approach where therapists of any background are trained to be culturally competent to work with different populations. And then the second major approach is therapy adaptations, which involves tailoring the actual therapy content. So across studies, client-therapist ethnic match has not been particularly effective. And to the extent that client-therapist ethnic match is effective, it may inexactly represent something else. So language match. So if client and therapist are speaking the same non-English language, they can communicate. Well, you need to communicate for therapy to be effective. So language match is important. Client-therapist ethnic match may also signal cultural competence. A client of a particular ethnic background seeing someone like themselves may infer that therapist understands them, but if the therapist is very acculturated or not in touch with their own cultural background, they may not be culturally competent. What client-therapist ethnic match may do is to prevent premature termination. So if a client comes to therapy, sees a therapist that looks like themselves, they may believe that the therapy is intended for them and this client understands them. this therapist understands them. And clients do need several sessions to experience a therapeutic dosage of treatment. So staying in treatment is a good thing. You want a client to be in treatment, and having a therapist of the same ethnicity may accomplish that. But client-therapist ethnic match has limited effects on therapy outcome or improvement. So deeper components such as cultural adaptations of the treatment may affect outcome, but client-therapist ethnic match per se only get you so far. Cultural competence is another area in which adaptations have been introduced. This is Joyce Chu, and she and her colleagues discussed awareness, knowledge, and skills. That's a classic cultural competence model. Many of you are probably aware of that. I know some of you are clinical psychologists. So cultural awareness involves one's awareness of one's own personal values and biases, a knowledge of the client's cultural background and worldview, and then a knowledge of the client's therapy expectations, and then the skills to actually provide culturally competent therapy for a client. So that's the cultural competence model, and many training programs try to train culturally competent therapists. But across studies, cultural competence only goes so far as well. Therapists' perceptions of their own cultural competence are not associated with their clients' experiences in therapy. Well, why is that? Well, not all therapists who perceive themselves to be culturally competent are perceived by clients as being culturally competent. So clients' perceptions of therapists' cultural competence are associated with longer participation in therapy, which is a good thing, and they're mildly associated with therapy outcomes. So therapist-client cultural matching, therapist cultural competence give us some advantage with clients of color, but are not the whole story. This is Guillermo Bernal, my colleague in Puerto Rico. He has developed an elegant model of cultural adaptations that involve the systematic modification of a treatment or intervention protocol to consider multiple factors, including language, culture, context, that is compatible with the client's cultural patterns, meanings, and values. So Guillermo Bernal has been a leader in this area and has provided some useful frameworks for cultural adaptations of psychotherapy. This is a meta-analysis that my colleagues and I did almost 10 years ago now of the studies on cultural adaptations. And this plot are all the effect sizes lined up next to each other. And what we found is that across 78 studies with almost 14,000 clients, culturally adapted treatments work about 2/3 of a standard deviation better than did non-adapted treatments or no treatment at all. So culturally adapted treatments actually work. Changing the content, doing some of the things that Guillermo Bernal recommended actually works in terms of improvement, and improvement involved different psychopathology outcomes such as anxiety, depression, and psychosis and substance use. But culturally adapted treatments have not reduced mental health disparities. Why? Well, part of it is the limited availability of culturally adapted treatments. So not every service provider can deliver these treatments. They also tend to be very complex. And so Guillermo Bernal's model is very comprehensive, but it's very complex. It takes a lot of time in terms of training and is expensive to deliver. And also, culturally adapted treatments are sometimes broadly applied to address cultural features associated with a particular group. So as I mentioned earlier, a cultural adaptation for Chinese Americans that's applied to all Chinese Americans may not take into account acculturation, for example. So a person who's very acculturated may not benefit from the cultural adaptations designed for Chinese Americans. So my colleague Wei-Chen Wang has this elegant model of cultural adaptations for Chinese Americans. And I had a grad student a few years ago whose parents are from Taiwan, but she was very acculturated, and she read his model, and she thought, well, some of this works, but some of it I don't understand. So even adaptations for a particular group, if they're broadly applied, may not apply to every individual in that group. So the individual level involves what we call personal relevance, and personal relevance is how meaningful and how useful an intervention is to a given person, and whether the treatment approach being used is seen as credible and matches clients' belief systems and perceptions of what would be beneficial to them. So this is also known as precision medicine. How does this particular approach work for this particular person given their particular cultural context? So I want to give you a case study. So this is a client that I saw actually many, many years ago. His name is John. That's not his actual name, but he was a 13-year-old Chinese American immigrant. I was working in Los Angeles at the time. And the presenting problem was that he was sent to juvenile hall for stealing school supplies. He went into the school on a weekend and got into the school and stole some supplies. And so he was referred to the Asian American Service Center where I was working. And he was very embarrassed. He was remorseful. He did not want to talk about his problems, but he felt badly, and he felt like he regretted what he did and didn't want to do it again. So I tried to focus on decision-making with him. And, why did he decide to do this? What led up to his decision-making? Where did he go wrong in his decision process? So it was very difficult working with him because he didn't want to talk. So he just said, I'm sorry, I'm not going to do it again. But, that wasn't enough. So what would you do? This is a question for you. If you had this client who didn't want to talk, who wanted to stay out of trouble, how would you engage him? What would you do? And I'm looking for anybody's thoughts or ideas about this. How would you engage this young man? Yes?
Well, it doesn't always have to be about the problem. How about how was your day, or just anything beyond that? Maybe you can get him into the flow of talk.
Yeah. So not so much of a focus on the problem, but just get him engaged somehow. Okay, someone else. Yes?
I think you need to contextualize problems, so actually figuring out what else might be going on in his life from a personal standpoint that may have motivated him to react in that specific way.
Mm-hmm. Yeah, he really didn't want to talk, though. I mean, there probably was a lot going on in his life, but he just, he said, what I did was wrong. I'm sorry. Yes.
Storytelling, either telling him hypothetical situations, having him tell stories. So it's not about him, but about decision making.
Mm-hmm. Okay, so start taking the focus off him. Yeah. Yes.
I might challenge the idea that what he did was wrong, and sort of a vision of future where he became a successful criminal, and sort of talk about what the opportunities would be that are there for him, and what would be the risks and benefits of pursuing this. Because I think the sort of notion that I just need to tell you it's wrong may or may not be valid for this youth.
Yeah.
And so if you could really maybe get him to open up about that and his context, and whether there are successful, people in his context who make a lot of money doing criminal behavior, things like that, that we could really get into that and talk about that as a vision for the future, and then sort of explore whether that made sense for him.
Yeah. Okay, these are all great ideas, and I kind of wish I had you there when I actually saw this guy. So here's what happened. So there's a chess set in this center, and I suggested we play chess, and this was just serendipitous. I was just at wit's end. I was trying to figure out how to engage this young man. And so we started playing chess. And I'm not a great chess player, and neither was he. But playing chess, he liked playing chess. And actually, over time, so at the end of each session, we'd play chess. And his chess skills actually improved. And I didn't have some master plan about using chess to teach him a life lesson or something like that. But what he realized was that being mindful of chess moves was similar to being mindful of life decisions. So he said that to me, and he says, "Hey, you should use chess as therapy." I mean, he said that to me, just kind of on his own, and that's actually what happened. Is that he did see chess as a metaphor for his life and making decisions. So it was a form of problem solving involving chess that was indirect, took the pressure off him, and it allowed him to save face by indirectly addressing his problem. So I think someone said, take the focus off him and even the right, wrong aspect. It's a matter of, okay, here's a way, you made some decisions. Maybe there's another way to make decisions in the future. So I'll move to the personal relevance of psychotherapy. So Stanley Hsu and Nolan Zane have a classic American Psychologist article in 1987 that focuses on credibility and giving in a psychotherapy relationship. So credibility involves, is the treatment perceived by the client as beneficial? And also, secondly, the giving part is the treatment perceived by the client as practical? So is there some immediate effect or relief that the client experiences because they've been in the treatment? And this is analogous to Asian traditions of gift giving. In Japan, it's known as omiyage, where when you meet someone for the first time or visit them, you bring a gift to them. And so the Asian American client may be expecting some kind of immediate relief and a gift, a symbolic gift that shows that I'm going to improve, there's hope for me, and this may come in the form of symptom relief or reassurance that there's hope for me, I can change, something's going to happen. It was worth coming to therapy and seeing this therapist despite concerns about loss of face. So is there some immediate gift, and is the therapist credible? Jin Kim, who did some work on the credibility of therapy, as you know, Asian Americans are the least likely group to seek mental health services. So what Jin Kim and Nolan Zane found was that relative to white Americans, Asian Americans view therapy as less credible and have lower intentions to seek help, and credibility and help-seeking intentions are correlated. So if you think therapy is not credible, you're not going to seek help. And so that may explain the mental health utilization disparity that Asian Americans don't view therapy as credible and therefore don't see it as something that is for them. Personally relevant therapy involves approaching personal issues as solving specific external problems, which can save face and provide a practical gift. So similar to my client, the focus is off the self and the focus is on something practical, like solving problems in the family or school or work settings. And Joyce Chu and her colleagues developed problem-solving therapy for depression as a personally relevant intervention for Chinese older adults. And Chu and her colleagues thought that PST, problem-solving therapy, would be a good cultural fit for Chinese older adults who refuse treatment because it's directive, goal-oriented, short-term. It's not emotion-focused. And the core elements of PST are very specific and defining a problem, setting a goal, generating or brainstorming solutions, evaluating pros and cons of solutions, choosing a solution, implementing the solution, evaluating the outcome. So it's very action-oriented and produces immediate results. And so what Joyce Chu found is that focus groups with service providers and in focus groups and with service providers and an elderly client, she found that this approach was acceptable, and she integrated the input from these groups in a treatment manual, and she applied the core elements of problem-solving therapy with some cultural adaptations, but basically the tenets or the core concepts of problem-solving therapy were intact with some cultural adaptations, and she found that this improved mood in a depressed elderly Chinese woman. So this was the impetus for some of the work that my colleagues and I began, and Joyce Chu was part of our team. So how do we address mental health disparities with personal relevance? Well, this is a picture of the brain, and personal relevance can be assessed with neural functions that I'll discuss in a minute. But if your brain's telling you that something's personally relevant, your brain's not going to lie, right? I mean, this is your brain. This is the most personal aspect of you that gets at you as an individual and focuses on your own personal individual preferences. So we've done some work with social neuroscience at the University of Oregon with fMRI. And Petty and Cacioppo in social psychology have proposed the elaboration likelihood model of persuasion. And peripheral processing involves low message engagement or low likelihood of attitude change. So if you're on social media and you're a young person looking for new shoes, and you see an advertisement for an old folks' home, you're not going to pay attention. That's peripheral processing. You just ignore the message and look for something else. Central processing, however, involves high message engagement and high likelihood of attitude change. So if you're looking for new shoes and you see an ad for shoes, you're going to look at that ad and you're going to pay attention, and you're much more likely to buy those new shoes than respond to the ad for an old folks home if you're looking for shoes. And central processing is associated with neural activation and attention and self-processing networks. So in terms of personal relevance, neural activation increases in self-processing networks, including the medial prefrontal and posterior cingulate cortices, is implicated in central processing of persuasive messages. So you can actually measure personal relevance based on neural response. So in some of these studies that we've conducted in Eugene, we compared cognitive behavioral therapy and problem-solving therapy. Cognitive behavioral therapy is an evidence-based treatment that is kind of the standard of evidence-based treatments. And problem-solving therapy is another evidence-based treatment that is much more practically focused. Cognitive behavioral therapy focuses on thoughts and feelings, and so there's lots of face loss potential, and there's a self-focus. And in contrast, problem-solving therapy focuses on goal setting and external problem solving. There's a potential to save face, and problem-solving therapy may be particularly relevant to many Asian Americans, particularly those who are unacculturated and are looking to succeed in society, try to learn English, try to do their job, try to do well in school. All of these practical problems that they're facing might be addressed directly by problem-solving therapy more so than the self-focus on thoughts and feelings of cognitive behavior therapy. So we did a study, a proof of concept study, where we hypothesized that personal relevance of problem-solving therapy would be greater than the personal relevance of cognitive behavior therapy. And again, the external problem-solving approach allows a client to save face in family, work, and school contexts. There's not a focus on the self. And external problem-solving provides something immediately practical, a symbolic gift for Asian Americans. So we did a brain imaging study. We had 28 Asian Americans from Eugene, Oregon. We had first, second, and third generation Asian Americans. Presumably, first and second generation Asian Americans are less acculturated than those who are whose grandparents were from Asia. And we randomly ordered excerpts from cognitive behavioral therapy or problem-solving therapy treatment manuals and presented them in an fMRI scanner. And fMRI, if you're not familiar with it, is brain imaging while a participant is engaged in a particular task. So these are randomly ordered excerpts. The people in the study didn't know if this was CBT or PST. They just saw excerpts, and I'll give you a couple of examples. So a CBT excerpt was, when we look at your thoughts, sometimes they're true, not true, or have a grain of truth. We will teach you how to evaluate the accuracy of your thoughts by looking at the evidence. What evidence is there that the thought is true? What evidence is there that the thought is not true? So we had many examples of CBT excerpts. This is just one. This doesn't represent all of them, but this is a representative example. And then a PST example was one skill that may help you as a generation of alternatives, in which we teach you to use your creative skills to brainstorm different types of solutions. You will come up with as many solutions as you can. Not all will be the best solution, but it helps you to think of alternatives. For example, if you're struggling to talk to your roommate about cleaning up after themselves, you can use the brainstorming tool to discover that there are many ways to get closer to your goal and get past the obstacles in your way. So you'll notice that this is a little bit longer than the CBT vignette, but we did control for length across all of the vignettes. So this is an example of PST and is not the only one. So what we found in this study was that that neural response to problem-solving therapy compared to CBT was much more in the medial and ventromedial prefrontal cortex. So that's this area here. So this neural response was much greater in response to problem-solving therapy vignettes than it was to cognitive behavioral therapy vignettes. So that's what this slide and these other slides indicate. And these are statistically significant. And in the other slides, the ventral striatum is shown. So in these areas of the brain associated with personal relevance, there was much more activation for problem-solving therapy vignettes than for CBT. So this is a proof of concept study. And then we also found that this difference in response between PST and CBT was more pronounced for first and second generation Asian Americans than it was for the third generation Asian Americans who were more acculturated. So this preference for CBT indicated by neural response was much greater for first and second Asian Americans than for third generation Asian Americans. So this is a proof of concept study. And my colleague Elliot Berkman, who's a social neuroscientist on the project, told me this is a slam dunk. And this is not my area, but he did all of the data analyses with thousands of these images, and we got a very consistent and strong result. So the question is, well, is this finding specific to Asian Americans, or does everybody think that problem-solving therapy is more relevant than cognitive behavior therapy? And we didn't have funds to do further neuroimaging, but we did a self-report study with college students to look at the personal relevance of CBT and PST with Asian American and white students. So we looked at personal relevance, how much they liked the approach, and how helpful they found it. With European Americans, you found a slight preference for PST, but these differences were not statistically significant. So essentially, European Americans saw both approaches as helpful, PST and CBT. On the other hand, for Asian Americans, these are statistically significant differences in self-report, where they saw problem-solving therapy is more personally relevant, they liked it more, and was more helpful than cognitive behavioral therapy. So the summary is that neural activation and self-report suggested that a pragmatic treatment approach is more personally relevant to Asian Americans and was a self-focused approach, and that this PST versus CBT advantage was more pronounced for immigrants and their children. And self-report indicates that PST preference in personal relevance occurs for Asian Americans, but not for European Americans. So what's next? So let's extend the reach of these interventions. I had some colleagues in Eugene who had developed therapy apps for different groups, and they approached me saying, let's develop an app for Asian Americans. So an app is great because it's on your phone, it's private, you don't lose space, No one needs to know that you're doing it. You can do this in your privacy. You don't have to go to an actual therapist, be seen in public, and so forth. And many people have phones, so this seemed to be a logical extension. And so they wanted to scale up these findings, these neuroscience findings, and develop this PTSD app to address stress among Asian Americans. So we wanted an app that didn't involve stigma. Everybody experiences stress, and so our rationale was that a stress reduction app would be seen by many Asian Americans as applicable to them. In contrast, an anxiety app or depression app or something like that would be, there's some stigma involved with that. Stress reduction, hey, everybody can use stress reduction. And we got some funding from the Small Business Innovation Research Program of NIMH. And the timing was good because this was when anti-Asian violence was happening during the pandemic. So we got funding to develop this problem-solving app. Art and Christine Nezu are on the team, and they're founders of the problem-solving approach. And as I mentioned before, the privacy of a phone and an app reduces stigma. A person could save face. We used Asian American characters, and we had an Asian American cultural context. There's a panda that's kind of the host of the app, and we focused on practical problems. So the app was called is called Mind Boba, and I wish that was my idea, but it was one of our younger Asian American research assistants who came up with this, who thought, hey, and Mind Boba wasn't copyrighted, so we got Mind Boba copyrighted, and so Mind Boba is our approach, and this is some images from the app. You can see this panda who's the host. You have these Asian Americans who are experiencing different stresses in their life, and there's a karaoke place and a boba tea shop. And here's the panda that leads you through again, and here's the three Asian Americans. And the idea here is to show that Asian Americans experience these problems just like anybody else, and that you can benefit from their experiences and customize this to your own experiences. So there's different modules: solution, mission, brain boosters, motivation, emotion, just to get a person primed to do the intervention. And there's goal setting, brainstorming, creating a plan, reflecting, all hosted by this panda. So to conclude, and so we're developing this. We're getting some preliminary data in. Unfortunately, with the cuts to NIH, my data analyst is kind of trying to exist or trying to survive, so it's been hard to get much content. We've had some discussions, so we're analyzing the data. We've run a randomized clinical trial, so the data are kind of trickling in. But we're hopeful that this might be something that could be useful. So to conclude, Asian Americans continue to be the least likely group to use mental health services. Universal group or individual approaches in isolation have not reduced disparities, and a personally relevant therapy that addresses practical problems can attract Asian Americans to therapy. So we've developed this app. This is not to replace actual therapists. Any therapist treating Asian Americans can consider what practical issues there are going on in an Asian American's life. Again, some Asian Americans are going to be amenable to mainstream conventional approaches such as CBT because they're acculturated or because they took a class in college and learned about CBT. But other Asian Americans, particularly those who are unacculturated, may be looking for something more practical, such as problem solving. So I want to acknowledge the SBIR funding on this mHealth problem-solving intervention to reduce stress to develop our app. And I thank you. Yes.
Hi, thank you for your presentation. I'm curious to what extent, and I know some, big samples are difficult with this type of research, but to what extent you had variation on other social factors like class. Because one thing that struck me is, how applicable this might be to any marginalized group, this kind of preference for practical solutions. Like they need to get over that first before the luxury of, how they think about things. And so I was just curious, your thoughts on that, or to what extent you were able to get at that with your research?
Yeah, so the question is how a practical problem-solving approach might be applicable to any marginalized group, and it could be. It's just a matter of it's this precision medicine approach, matching the person to the type of therapy that would be most relevant to them. So any immigrant group, for example, might find this helpful. And some immigrant groups that are not Asian have some version of loss of faith. So I was talking to colleagues in West Texas a few years ago about loss of faith, and there were some Latinx folks in the audience who said, yeah, this is, loss of faith is something that is familiar to Latinx communities. So, I mean, some of these principles apply to other groups, and that's the hope, is that this kind of approach could be applied in other settings. Also, I think an advantage of this personal relevance approach is that you can take a therapy essentially off the shelf and modify it in ways that don't involve extensive reconceptualizing of the approach. You can retain the principles of the approach and apply it effectively to a group. Now, it does involve some adaptations, and you saw the types of art and animations that we did for our approach, but this is something that could be done for other groups as well. The idea is to make the approach seem personally relevant. That this was meant for you, whereas I think the universal approaches are seen as developed for somebody else, and even making some cosmetic changes could be helpful. Language translations. I mean, that's something very basic that could happen. But apart from these superficial changes, having content that is relevant to a person is very important. So in terms of this face loss issue, if you have a group that's concerned about loss of face, whether they're Asian American or not, and you have an approach that's focused on the individual, it's kind of like me working with that kid in that Asian American Service Center. We're working at odds. I mean, he's embarrassed, and I'm focusing on what he did wrong. I mean, that's just going to turn him off. So you want an approach that's congruent with the person's cultural values. Sometimes that involves cultural adaptation. Sometimes you can do some relatively minor adaptations with an existing approach. Yes?
Thank you. This is really interesting. I had a question about, well, it's sort of a two-part question. One is that because we're talking about Asian Americans as if they're one group and you have a sense of differentiation. And then the other is this an effect with mental health, or is this a general approach to health, or in sort of enculturated disease model?
Right. So the first question has to do with the heterogeneity of Asian Americans. As I mentioned at the outset of the talk, Asian Americans involve at least 30 different cultural groups, and there is a lot of variability. But loss of face is a construct for many Asian American groups that is important. And I know it varies from culture to culture. Loss of face was developed in East Asian context, but I've learned that in South Asian context, there is a certain amount of loss of face. And there have been studies to show that different Asian American ethnic groups have different levels of loss of face. But loss of face is a construct that does apply across groups. Therefore, this type of approach that focuses on saving face could be applicable to many groups. And the question about whether this involves only mental health or health in general. The overarching goal is to apply this approach to all kinds of health. It's just that this disparity is a mental health utilization disparity for Asian Americans. Asian Americans don't underutilize medical services, so the reason for the focus on mental health is that this is an area in which Asian Americans are underrepresented in terms of their participation or their seeking help for problems that are very distressing that they're not getting help for. Yes.
Thanks. That was really wonderful. Two questions. One is the app targeting a younger population? Because it seems the cartoon images reminds me of maybe a younger population. And the other question is, with the vignette for the problem-solving therapy versus CBT, first of all, just the idea of measuring responses from explanations of the therapy is really interesting to me. I noticed that the CBT one did not include an example, whereas the PST one included an example, which someone might then put themselves in that situation. I was just curious if the CBT ones also included examples?
Yeah. The CBT ones did include some examples. So they were, as I said, they were counterbalanced for length and content. And those, it looked like sure, I liked the PST one because it had an example that I could actually use. But also PST is very practically oriented. So it is focused on problems. And CBT, actually problem-solving therapy is a component of CBT. So, but CBT tends to focus on, thoughts and monitoring feelings at the outset, whereas problem-solving jumps right in with problem-solving. So Wei-Chen Huang, who's on our team and is a CBT expert, said part of it might be just the sequencing of the approaches, to start with problem-solving and then get to cognitive distortions and some of the other CBT components later on in the process. And your first question was?
Whether the app is targeting a younger...
Oh, yeah. So it's targeting a range of people, but the examples there were younger people. I do have some preliminary demographic data, and actually the people that came online to be in the randomized clinical trial were, I think the mean age was close to 40 years old. So you have people that are probably older than these people using the app and seeing it as useful to them. I suppose we could have used a range of people in age, so old people like me could see that it's for them. But I think the idea was to just make it something engaging and sort of contemporary and boba and so forth. And by the way, someone asked me what my favorite boba tea is, and I sheepishly had to admit that I really don't drink boba tea, and maybe my daughter can tell me what one is the best for me. Yes.
So let me start by saying I confess I should know more about this because I learned problem-solving therapy 40 years ago. Tom Buzzarolo was my first clinical supervisor, so I should have some sense of this. But the question I have is, how does it work? How does problem-solving therapy work, and does it work the same for Asian Americans as it does for other populations? And the reason I bring that up is because I've sort of naively always assumed that it works by shifting people's view of their problems, by seeing the things as problems to be solved, not overwhelming stressors to be to be born, and maybe also by delaying a little bit the action part. Because I would have, this is going to be maybe stereotype, but I would have stereotyped that a lot of the people that you might be working with probably are problem solvers. Mm-hmm. Like that's probably their orientation already. Yeah. And so if you're just giving them more of what they already do, that doesn't tend to work clinically. Mm-hmm. So I guess my question is, do you think that PST works by shifting people's attitudes toward our problems, or by actually the way that you would think it works by helping people solve their problems?
That's a great question. Are we just telling people to do what they're doing or activate something that's already going on. There's a Latin term, age quod agis, do what you're doing. So it's like, you're doing a good, you need to focus on your successes. I mean, that's a good question. I would say that, sure, there's a cognitive shift, but I think this gift-giving idea is important. Seeing, some actual success, and I guess it's a form of reinforcement, just seeing that, hey, I can change my behavior, I can do things a little bit, I can follow this approach, and I get something out of it. I mean, something benefits me, whereas and that probably is the process by which cognitive behavior therapy works as well, but it's a longer process. So if you can get some immediate gift, immediate benefit, then you're kind of hooked and you think, hey, this is for me. And actually this approach could get a person interested in cognitive behavior therapy or in therapy, in seeing an actual therapist. So a person could do this app and say, gee, in fact, that's what we do at the end of the modules. We say that, if you want to do more work on this, or if this app has been helpful, or if it hasn't been helpful, you might consider seeing an actual therapist. But, that's an interesting question about the mechanism. I don't know if we've actually identified what the process is, but in terms of this neuroscience work, it does seem to be what we're calling personal relevance. This is personally relevant for me, so I'm going to pay attention, and it's going to hook me, so to speak, in a way that other therapies don't. So I don't know if that answers your question, because I'm not sure I have an answer. Yeah. Yes.
Thank you again for your presentation. I was curious, it sounds like this construct of loss of face is mostly being treated as like a barrier to care or contributing to like treatment underutilization.
Right.
Has it also been looked at as a potential like cultural explanation for like mental health or like distress, or and would that change with interventions?
Oh, so are you saying that loss of face is the cause of
Well, I'm curious if it could be
Yeah,
an explanation as well.
Yeah, so I guess maybe the question is loss of face itself something that is a source of distress, or something that a person needs to contend with or get over, so to speak? So that's an interesting question as well. Loss of face is a pretty pervasive cultural phenomenon in Asian American cultures, and it's not something that we can't. We can't just have a public health campaign and say, get over it, or this is something that and there are actually some positive aspects of loss of face. So early in my career, I was doing work on sexual aggression. We found that for Asian American men, those who were concerned about loss of face were less likely to be physically and sexually aggressive against women because of this concern about loss of face. So that's sort of the positive aspect of loss of face. But in this mental health context, it deters people from seeking help and could be seen as a problem itself. I think it's just too pervasive to try to remove, and there are. It's pervasive, and as I said, certainly in terms of aggressive behavior, it's something that is positive. Also, in social settings, for a person to stop being concerned about loss of face, they risk being ostracized or alienated in a group. So I think it's a matter of working with the cultural influence rather than working with it and coping with it to a certain degree rather than trying to remove. But that's a very interesting question. Is loss of face itself something that is the problem? it's a problem. It's a deterrent, I'd say, but I don't think it's something that. Yeah, I suppose an approach could be to address concern about loss of face, and I suppose some therapists actually do that, but I just think it's so pervasive that if a person's going to be less concerned about loss of face, they may need to find a new community where people don't care about it. Yeah. Yes.
I know you mentioned the variety of services provided by mental health providers, and I was wondering if any of this research or data has been adapted by different providers to better serve their clients.
Yeah, so the question is whether any of this data has been used by health service providers. This is very new, so I can't say how much it's been implemented. The culturally adapted treatments movement began about 30 years ago. That's been slow to take hold for a variety of reasons. So it's getting out there, but it's just slow to take hold. So one would hope that this would be applied, but it's expensive to deliver. It's expensive to train people, and an app is something that is very accessible. And again, it's not a replacement for therapists or training, but is something that can get directly to the user without having to train and go through all the expense that is involved in actual therapists. Okay, well, I have to say that I feel a little bit I feel a little bit like an imposter talking about social neuroscience, because my daughter Coco actually studied neuroscience as an undergraduate at the University of Washington, and I'm not a neuroscientist, so hopefully when I talk to her later, she'll forgive me for whatever I didn't say accurately. But But thank you again for having me. It's been an honor to be here. I've just really enjoyed meeting many students and faculty. I'm very impressed with UMBC and your psychology department. And it's just been a great time to be here. And thank you again for inviting me.
I must say thank you from the psychology department to Dr. Hall. This was really a great talk. I learned a lot, and there was a lot of great conversation as well. So thank you all for being here today, and thank you so much. Thank you.